Good afternoon, everybody. This is a session on clinician and ophthalmic pathologist interface. Our first talk is by a case of an orbital tumor and presented by Dr. Kasturi Bhattacharjee and Dr. Dipankar Das. Thank you.
Thank you very much, sir. It's really an honor to be with JB sir. Like, sir is my mentor, and he had taught me how to write a paper and the importance of writing a paper. And it's really a big privilege for me. I'll be speaking about something, a very interesting tumor. And when we talk about this tumor, my question to it that is it actually a tumor or a misnomer? Because I feel that it is more of a misnomer because we do not see any endothelial proliferation, and hence I feel it is more of a hematoma. And as per the ISFA classification, it still stands that it shows no endothelial proliferation, so it should be more of a hematoma. So this primary intraosseous vascular malformation is rare, and it usually involves a long bone. And the first case was reported in 1942, but orbital cases are much less, having a female preponderance. So what is the inciting factor? The factor is basically a trauma or ischemia. This incites angiogenic proliferation, and this along with the, is it coming? Angiogenic differentiation, and this along with a bony resorption and bony differentiation, it leads to the formation of a tumor within the bone, which we call a intraosseous vascular malformation. So if you look to this intraosseous vascular malformation, it can be in a single site or it can be a multi-site. But for us being an oculoplastic surgeon, we need to differentiate before the surgery because these are real vascular tumors. And one of the common differential diagnoses is fibrous dysplasia. But if you look to the tumor, if you look to the CT scan, you will see the fibrous dysplasia has more of a ground glass appearance as compared to the intraosseous malformation. Sometimes it gets difficult to be differentiated from meningioma, but if you look to the striations within the tumor, it looks more radiating as compared to the vertical striation that we see in the meningioma. So the definite diagnosis is by histopathology. I'll not go much into details. I have come here to learn from you all, but for me, being a surgeon, the treatment of choice is surgery. These tumors are real vascular tumor. You need to do an embolization. Like this is a lady which we have operated, and if you can look the tumor out here, and this is through a transconjunctival approach, and this is a tumor during the operation. So that the surgery involves that the end block of removal of the tumor. This is very important, and we have till date we have got 6 or 7 cases, and once we have removed the tumor totally, we have found that till today, even with a follow-up of more than 5 years, there is no recurrence. And since you are removing the tumor, it is very important that you have to do customized reconstruction of the orbital defect, the bony defect that you have created. This is the lady before and after surgery. This is another interesting case, but we knew that this is a vascular tumor, and when we had done a DSA, the feeder comes from the external carotid, so we had done embolization before taking her for the surgery, and then we could remove the whole of the tumor. And secondly, I would also like to share another case like this lady. The differential diagnosis was difficult because it was looking more a ground glass appearance, and so we thought to be more of a fibrous dysplasia, but when we had done the DSA, we found now the branches comes from the internal carotid. So we cannot go for embolization because the vision will be affected, but definitely we only to prove the diagnosis, we have done the incision biopsy, and it came out to be intraosseous vascular malformation. So this is do I have time? This is another very interesting case. She came to me like with this slowly growing mass, and this gives a typical honeycombing appearance that we have seen there. And then I have done the preoperative embolization, and you can see the feeder vessel. This is a branch of the external carotid. And after doing this, to be more specific, I have used the navigation system exactly to mark the tumor, because this is a tumor you really need to excise, and we all know that the treatment is full excision of the tumor. So this is something a very challenging surgery, but I really enjoy doing the surgery because this is a tumor involving the whole of the maxilla, where I had to do a very wide exposure, and this is how the tumor looked intraoperatively. As because we have already done the embolization, so we could remove the whole of the tumor along with the maxilla, and following the tumor removal, we need to do a bony reconstruction, where I have taken a rib graft, and then with the rib graft, the whole of the reconstruction has been done. And this is how we harvest the rib graft and done the reconstruction. And this is what she looks post-operatively. This is before and after the surgery. So I conclude here mentioning that this primary intraosseous vascular malformation is still a misnomer. It is more, I feel it is not a tumor, it is more of a hematoma, because Ki67 shows it is negative, and Ki67 negative means no endothelial proliferation. So, but one thing what I have realized, that complete excision is the treatment. And very recently we have reported this tumor in the journal Orbit, the 6 cases that we have seen during our course of management. Thank you very much for your patient hearing. Thank you, sir.
Good evening, respected sirs and ladies and gentlemen. I'll be showing the pathology of orbital intraosseous venous malformation. I do not have any financial interest in this material discussed here. Well, this is a 21-year female, what Dr. Kasturi has shown with radiological diagnosis of intraosseous hemangioma, and it was differential diagnosis was fibrous dysplasia of frontozygotic rim, and the sample measured accordingly in the grossing with other bits of tissue there. Now, in histopathology, it showed a thickened matured bone with internal vascular channel forming a lattice-like pattern in numerous RBC. Dr. Kasturi has shown there is a pattern of networking which was evident here in the intraosseous area of the hemangioma, and this is the enlarged view where you can see very minimally endothelial cell line in the cavernous spaces. Now, ISC already shared mention, CD34 was positive and Ki67 was negative in this malformation. If you see this publication, what are the catch points? Orbital intravenous malformation affects the orbitant bone, mainly the frontozygotic bone. It's a rare tumor, about 1% of the cases. Young and middle-aged adults are involved. Female were seen more often than male, and there is a honeycombing pattern that Dr. Kasturi has shown is evident in histopathology. Can have cavernous, capillary, or mixed type, and most important, they have to differentiate it from the other venous malformation or cavernous hemangioma that we see in the orbital center. Now, this is one of our publication showing a cavernous hemangioma with a cavernous spaces filled with blood vessel and endothelial lined cells with fibrous intervening septa. Again, this is again a scanning electron microscopy of another publication that showed the bone remodeling of initiated in intravenous malformation, where there can be a dysregulation of mTOR protein or P30K and other pathway involved in the intravenous malformation. Always to be remembered that VEGF in intravenous malformation can be there. So in conclusion, orbital intravenous malformation is a rare amongst all hemangiomas. They are little bit different from soft tissue vascular malformation. Thank you for patient hearing.
Thank you very much. Our next presentation is by a case of a lid tumor, and this is by Dr. Swati and Dr. Soumya.
A very good evening. So now we will be presenting a case of eyelid tumor. I'll be presenting the clinical part, and Dr. Jakati will be presenting the pathology part of the same tumor. So this picture, as you can see, is a picture of an old male who presented with complaints of lesion in the right upper lid. And he had this lesion. It was a very long-standing lesion. For the past 10 years, it was noted. The recent growth was noted in the last 2 years. He was coming for regular examination for his other ophthalmological condition, the retinitis pigmentosa, and he had some significant medical history, may not be directly related to the lesion, but he did have some medical history. His vision in both eyes was 20/50. Now, if we focus on the lesion, so this was the lesion which was present at the medial aspect near the canthal area. And it was purely involving the skin. There was no involvement of the posterior lamella that was noted. And there were no signs of, and if we look, whenever we see an eyelid lesion, what we always want to know is clinically whether it is a benign lesion or whether it is a malignant lesion. And there are certain signs of malignancy that we always look for whenever we suspect, and this becomes important because the management of a malignant lesion versus the management of a benign lesion are very different. Now here, if we see, the patient had no signs of malignancy as such, because there was, the skin was absolutely kind of like, obviously didn't have any ulceration, crusting. The lashes around that area were absolutely normal. It was not affecting or causing any changes that were signifying or that were hinting towards a malignant lesion. So with this, though it was not very cystic, we didn't do the transillumination test to tell that exactly this is a cystic lesion, but we do see these lesions very, very commonly, especially in elderly population, where they need not, though we call this epidermoid cyst or a dermoid cyst, even if we have, they will not have the cystic consistency to them, because they do have the solid component as well. So with that knowledge, we made a diagnosis of, probably because he gave a very long-standing history of 10 years, so we made a provisional diagnosis of epidermoid cyst, and we excised the lesion. Because we did not suspect any malignant lesion, we went ahead and did like a shave biopsy. We took out the entire lesion in that area and left that. It was like a pedunculated area. There was just a small defect which we could close directly. And we sent the specimen for pathology examination. Now, Dr. Jakati will tell us what happened in the pathology lab. Over to you.
Yeah, thanks, Swati. So what we see here is a solid cystic lesion on a scanner view, and on low power, what we see here is that there are solid islands of cells floating in pools of mucin, and on extensive sampling and on extensive sectioning, we tried to look for in situ areas which were not seen in this particular lesion. The lesional areas was focally solid and also had a cribriform pattern to the in focal areas, and they are traversed by fibrovascular septa at focal places. So lesional cells on higher magnification were mostly monomorphous. Very mild pleomorphism was seen. There were no mitosis at all, and there was a lot of myxoid background seen. And on Alcian blue, the lakes of mucin were highlighted. Both extracytoplasmic mucin and the intracytoplasmic mucin were highlighted. On immunohistochemistry, these cells were strong and showed strong and diffuse positivity for pancytokeratin, EMA, and CK7, whereas CK20 was negative. We also ran a panel for endocrine markers, so NAC was negative, chromogranin and synaptophysin were also negative. Ki67 was around 15 to 20% at focal areas. So we diagnosed this as mucinous adenocarcinoma.
Yeah, so once we have this diagnosis of this being a malignant lesion, there comes always a dilemma for the clinician whether we have to go back and do a wide excisional biopsy, because this patient, since we did not suspect a malignant lesion, we had just done like a complete excision of the lesion. We hadn't taken tumor-free margins. So always we have to think of, if this patient, we have to go back and take wide margins. Now this patient, since we did not, we have time, I guess, right? Okay, since we did not, the patient also was not very willing for a resurgery, because obviously because he had a very good cosmetic outcome, and he was like, this lesion has been there for 10 years, and he was not keen on surgery. So this patient, we did not go ahead with a repeat surgery. But of course, it's important for us to know whether this was a primary tumor or whether it was a secondary tumor. That becomes very, very important, because primary mucinous adenocarcinoma is not very common. So we did a metastatic workup, rather than that, a systemic surveillance to know if there is lesion elsewhere which has actually presented in the eyelid as a secondary. So this patient did not have any lesion elsewhere, suggesting that probably this is a primary mucinous adenocarcinoma. Now let's move to a second case. Now this again, the reason that we are presenting this is now this patient also had the same diagnosis, but the difference being that this patient was a young patient. As you can see on the slide, the patient was only 37 years old, and you already see a scar that is present in the subbrow area, indicating that the patient has undergone surgery before. And if you look into history as well, you can see that the patient has actually undergone 3 surgeries, and the diagnosis was different in different places. So he came with the report saying in one place where they called it as a chondroid syringoma, other place where they just called it as myxomatous degeneration and a dermoid cyst. So there were different diagnoses that the patient came with, and he had these multilobulated lesions which we could palpate very well. And the posterior extent of the lesion also was palpable. I haven't put the CT image here. He also had a CT which clearly showed that it was not extending deep into the orbit, but it was limited to the eyelid itself. And this patient, again, we went ahead and did excisional biopsy, like a wide excision. We didn't do frozen section for this patient. Again, because we did not clinically suspect a mucinous adenocarcinoma, that later itself we came to know after the histopathology diagnosis. We went ahead and did a excisional biopsy of this lesion, where the entire lesion, the skin could be nicely separated from the lesion. So we went ahead in a subcutaneous plane and removed the entire lesion. And Soumya will just show us the histopathology of this patient. We did not make this diagnosis. He had come with the diagnosis of the pathology. Yeah. So this we just gave, we didn't know exactly what this tumor was. I think we sent to the pathology lab as just adnexal tumor. We didn't know what tumor exactly. Yeah, that's what we just sent it as, like an adnexal tumor. What exactly it was, we did not know. So provisional clinical, we just kept it as adnexal and sent it to pathology lab. The diagnosis that we have listed there was he had come with the reports of these. Over to you, Soumya.
So on histopathology, again we saw a similar morphology as to the previous case, wherein there were islands of tumor cells which were very monomorphic, floating in pools of mucin, and they were separated by thick and thin fibrous septae. This is on Alchin blue, which is highlighting the mucin. And on IHC, again the tumor cells were positive for pancytokeratin, EMA and CK7. CK20 was negative. So then we concluded this as mucinous adenocarcinoma. Over to
yeah, in the interest of time, probably we can skip the discussion part and we can take questions later.
I think few points which we can highlight here is that GATA3 is one important IHC marker which you can do, which is very specific for these tumors. And the CK7 positive and 20 negative tumors, 20 profile should always point out that this is a mucinous adenocarcinoma. Endocrine secreting mucin producing adenocarcinoma will be a precursor lesion to this entity. And when the expression of synoptophysin and chromogranin is lost, then you can have this kind of appearance of the mucinous carcinoma. It's widely extensive, and for metastatic workup, you can also do CDX2 to rule out metastasis from other GI tract malignancies. And systemic workup is always advised. Thank you.
Thank you.
Well, thank you very much for an interesting presentation. Our next team is a case of a conjunctival lesion by Dr. Harsha and Dr. Shruti. You're going? Yeah, okay, I'll see. Then you come back. Yeah, right, okay, go ahead. Go ahead.
I start, sir? Yes. Thank you. I'll be presenting a case of conjunctival lesion which posed us quite a diagnostic dilemma as clinicians because of the age of the patient and the previous history, and where IHC and maybe the histopathology helped us in clinching the diagnosis and maybe deciding the further course of treatment. So it's not changing. Slides. No. Yeah. Okay. So this was a 9-year-old male patient. He was on treatment with us since almost 5 years of age for allergic eye disease. And as we can see here, classically he has this limbitis picture and with classical limbal VKC. And he has been on and off steroids, mast cell stabilizers and multiple lubricants for a period of 4 years. And this was a routine for him, almost seasonally. But this time when he came to us with this clear-cut nodule. He has a well circumscribed lesion of 5 to 6 millimeter. It was not attached to underlying structures, and it was rose Bengal stain negative. And also the patient, because most of these allergy patients keep using steroids on and off by themselves. He had already used it without even our prescription. When he came to us, we thought that one option was maybe it was a foreign body granuloma, but however, the absence of congestion in the surrounding areas ruled this out. And other things that we were keeping in mind was whether it was a benign reactive lymphoid hyperplasia or a lymphoma. That lymphoma, very uncommon at this age, but the classical Salmon patch appearance with corkscrewing of vessels made us think about this diagnosis here. So we also did a ASOCT and noticed that there was a very well circumscribed lesion, quite homogeneous. But what was interesting was these dot-like structures here. These are suggestive of maybe activated or reactive lymphocytes. Maybe so that's what made us think it was maybe BRLH. And we decided to proceed with the excision biopsy with cryo and AMG, and intraoperatively it is a homogeneous mass of tissue with no fluid or no cysts involved. So we got our HP reports here. So it suggested again similar to what our clinical diagnosis was, lymphoid hyperplasia, but again not sure of whether it was reactive or atypical. And so we used IHC for further diagnosis. So this was the IHC report. I think Shruti will be discussing it later. So it came as B-cell lymphoma. For clinicians, for us, all this is like Greek and Latin. I cannot make this out. So I have a pathologist at home, who makes it simple for me. So final diagnosis was allergic eye disease with extranodal marginal zone B-cell lymphomas in the left eye. So based on this report, we referred the patient to an oncologist. Patient, when they first went to oncologist, they were suggested to undergo MRI, brain, PET scan, complete evaluation. And based on the reports, they were told to observe every 3 to 6 months. Since it was a child, parents were quite concerned, took him to another oncologist where they were told to repeat the IHC. Here, as opposed to our reports, it showed us K67 index to be low, and so the diagnosis is low-grade marginal lymphoma, and just suggested to be observed, and in case of recurrences, to undergo radiotherapy. Again, they took another opinion. They were just told to observe every 3 months based on the older reports. And later, 1 month later, the patient comes back to us with again congestion bilateral. Patients were very concerned. And this here shows that this is a classical allergic eye disease. This is what I recurred. You can see this limbitis here, diffuse congestion in both the eyes, well scarred area where we operated, and the limbitis. So we just reassured them, put them on allergy treatment, and this time got an allergic workup also. It came out as allergy to dust mites and pollen, gave them slit therapy also, and maybe with steroids it did resolve. But again, once we stopped the steroid, the next day, patient did come back to us with mild subtle congestion. And this time we can notice that there is no limbitis, but there are very subtle lesions in both the eyes. This you can see there's little hypertranslucent areas here, multiple. So this definitely is not allergy. And since we knew this earlier, it was lymphomas, we were suspecting if it has recurred. So the treatment options in front of us were whether he needed repeat excision biopsy. We knew this. We knew that the diagnosis already. So even if we do it again, I don't think we are going to get anything different. And the other option was to observe the patient, and we also explained to them the role of topical treatment like interferons and cyclosporin. And since the oncologist had mentioned about radiotherapy, we also gave the option to them. Also, there are multiple treatments that has been explained in the literature. So when we looked at the literature, when we looked at especially the children with lymphomas, very few reports have been published. Almost maybe 10 or something. With children less than 10, it still narrows down to maybe around 8 or 9 cases. And so that brings us, for a clinician like me, I mean, we see multiple, in a day we see around 3 or 4 allergic eye disease, chronic ones. So is this chronic allergic eye disease a stimulus for these patients to develop conjunctival lymphoma? So it's quite important for us to not treat all these recurrences with congestion as just allergic eye disease, but to look for any other coexisting lesions. And also sometimes these lesions can respond to steroids. So it's more important that any atypical things, we send it for histopathology. And children with conjunctival lymphomas need long-term follow-up and monitoring for systemic lymphomas. Yep. I think Shruti can continue with.
I can't change you. So good evening all. So as Dr. Harsha has already discussed, this turned out to be a case of extranodal marginal zone lymphoma on IHC. So when we're talking about conjunctival lymphoma, the most common morphological histological type is the EMZL. It's a mild lymphoma, a B-cell lymphoma, and followed by follicular DLB cell mantle zone lymphoma, and T-cell lymphomas are extremely rare. So what was interesting was this case. There are a handful of cases of conjunctival lymphomas, and there's this large group study wherein Dr. Asha has already shown the number of cases. So as was also this rare case. So this turned out to be EMZL on histology. So what you can see is monotonous diffuse sheets of cells. And there are a few lymphoplasmacytic cells as well. And the IHC was positive for the B cell markers, and BCL2 and CD43 is commonly seen in the pediatric EMZL. So all other stains were negative, ruling out other histological types like follicular, DLBCL and others. So this is a low-grade extranodal marginal zone lymphoma. And what I want to highlight here is our case was a known case of atopy. He was a child with a autoimmune, with a allergic eye disease. So these cases are one of the, this is one of the risk factors for development of EMZL. So this is what we want to highlight with this case. So these children should be in close follow-up, and any atypical appearance of lesion in these children, they should be biopsied and sent to pick these lymphomas early, even before the systemic spread. Thank you.
Thank you very much for that nice presentation. We'll call on the next team, Dr. Manisha Agarwal and Dr. Arpan Gandhi, to present a case of endophthalmitis. So while they're coming up on the podium, I just had a comment. We have a case hidden in the literature. This was pre-IHC days. By Steve McLeod and I published a case report of atypical lymphoid hyperplasia in a child with a very similar picture. We had no IHC. And then about 10 years later, we went back and took a look at the case, and it was very similar to yours, a very low-grade lymphoma, but the child did well. The point is, I don't know how many calls I got from around the globe, because that was the only paper there on a pediatric lesion in the conjunctiva. And we said our patient did fine, and but with all the immunostains, it's we have another worrisome diagnosis in a child. Yeah. Thank you. Please go ahead.
A very good evening to all of you. I and Dr. Arpan Gandhi, we would be together presenting a case of endophthalmitis. So can the AV team help me to move my slides, please? So Dr. Arpan is heading the lab services at our hospital, Dr. Shroff's Chartier Hospital in New Delhi.
पहले उनकी
Thanks. So I'm presenting the case of a 40-year-old male patient who presented with sudden painful diminution of vision and redness in the right eye for last 1 month. He had a history of uneventful phacoemulsification surgery with IOL implantation 2 months back, and he had been diagnosed with endophthalmitis elsewhere, same institute where he got operated, and treated with one intravitreal injection of a combination of antibiotics. The details were really not known. So this is how the eye looked. The vision was 624N36. It was a highly inflamed eye with an element of corneal edema, a lot of fibrinous reaction over the IOL with hypopyon, AC cells and flare. And as far as the fundus is concerned, there was an extensive vitreous haze. However, second order retinal vessels were visible. So we took an AC sample and it was sent for the microbiological examination, both for bacteria and fungus. An intravitreal injection of vancomycin and deca was given, and the patient was started on oral antibiotics and oral steroids. And the patient started resolving, and he started showing a response to the treatment, which was provided as a first-line management without any microbiological backup. And there was a gradual improvement in the condition of the patient. So 1 month later, again the patient presented with diminution of vision and a circumcorneal congestion, streak hypopyon, fibrin over the IOL, and the vitreous showed exudates with no fundus details seen. And the AC tab that we had sent earlier came out to be all negative, and there was absolutely no growth. So we didn't know what organism we were dealing with. So this time we were a little more aggressive, and we went ahead and did an IOL removal with core vitrectomy, and intravitreal injection again of the same antibiotics was repeated because the patient had shown a good response the first time that the patient had presented to us. And this time we sent the sample of the vitreous and the IOL sample again for the microbiological examination. Post-operatively, the patient looked quite good. There was a good red glow, and the AC looked pretty quiet. There was a mild circumcorneal congestion which was expected after the surgery, and the patient of course was aphakic because we had removed the IOL. The sample of the vitreous that was sent to our lab on KOH examination showed septate curved fusiform macroconidias, which are classically described as banana-shaped colonies, and it came out to be Fusarium species to our surprise. So the patient was on topical and oral steroids, which were stopped after the microbiome report came in, and the patient was started on oral antifungals as well as topical antifungals, and the steroids in all forms were stopped. Intravitreal voriconazole was repeated every 24 hours for 3 days and then every alternate day. On culture also, there were the growth of these fluffy white colonies on blood agar and Sebrot's dextrose agar, which were suggestive of Fusarium solenis species, and I'm sure Dr. Arpan will add more knowledge to us. And 2 weeks post-operatively, there was a recurrence again of exudates in the vitreous cavity, and a revitrectomy this time again was done, and an intravitreal voriconazole was given with post-op voriconazole injections. 5 months, the patient was absolutely good. The media had cleared up. The BCV in the right eye had improved to 20/60 and 18. But 6 months later, the patient came back again with a drop of vision to hand movements, with gross lid edema, chemosis, congestion, AC reaction, hypopyon, and this time we could see a ball of fungus right behind the iris, which is the predisposed site for any fungus to grow because it is a cool area and it's a dark area behind the iris. And this is on a more magnified view where you can beautifully appreciate the fungal ball behind the iris. So we knew that the vitrectomy, IOL removal had all gone waste, and the patient was still having a persistent fungal infection behind the iris. So we decided to do a transscleral cryotherapy, a double freeze thaw to the fungal ball, and oral, topical, and intravitreal vorikonazoles were again restarted for this patient. And this is just a short video. This is something which we do when we see these fungal balls behind the iris, because we know that this is already a vitrectomized eye, and this basically helps to destroy the fungal cells. So this is the cryo probe, and on depression you can actually approach the fungal ball area behind the iris, and with a double freeze thaw you can actually damage the fungal cells. So the eye was quiet with a low digital pressure, and therefore we had to resort to a revitrectomy with silicone oil injection, And on regular follow-up, now the eye was quiet. The patient had recovered a vision of 636 N36. The pressures were good. They were 80 millimeters of mercury. The eye was quiet, and you see a good fundus, well-attached retina with silicone oil in situ with some amount of ERM formation. So post-op endophthalmitis is very much a true ocular emergency, as we all know, and it's a potential complication of any intraocular surgery. We should be knowing how to differentiate between infection and inflammation. And the clinical diagnosis, of course, has very typical symptoms and signs. But what we need to understand is when we are dealing with a fungal endophthalmitis, the symptoms can be very less in comparison to the number of signs that we are having. And we also have to look for a risk factor for the development of endophthalmitis. And I'll just request Dr. Arpan now to just add a few words of wisdom on the microbiological examination.
Thank you, Dr. Manisha. So my talk is basically on the need for how a super specialized or a specialized lab can actually handle samples not only for microbiology, for cytology, we even make cell blocks. So the talk is we get samples from within the hospital and from outside the hospital. So the extreme importance is the conversation between the clinician and the microbiologist and the pathologist to happen. Dr. Manisha, if she has a case, she informs us either a day before or on the day. So we are prepared, and we know that's a high priority thing. We've heard of tumors, but we know what endophthalmitis can do to any of our patients, and we don't want to be going there. So it's very important. I'm not going to read out everything, but what we need to know is these steps to send samples are extremely important. My talk is very microbiology related, but it also means that whatever sample has come in from the vitreoretinal department has to be handled in one go for microbiology, for cytopathology, for cell block, all in there. You don't want to go back to the OR and ask Dr. Manisha and her team, please send us more diluted or pre-diluted sample. It has all to be processed and done in one go so that the answer to the clinical team is in total. So I'm going to just run through a few slides and just tell you why it's important. A KOH seen, informed through to the doctor is extremely important for them to start the direction in thinking. We saw that there's a case where they probably did not think it to be that, but it could just give them something to immediately start. A case at 6:30 in the evening with a KOH report is something that the clinical team and the patient care would definitely appreciate. We do gram staining and we do cytospins. We have a lot of ocular pathologists here. They would know the importance of seeing neutrophils, viral cytopathic changes, do a cell block, and even look for, we've had cases of atypical lymphoid cells also coming up. So it's very important that the sample coming into the lab goes through all your processes. We are lucky that everything is on one floor, under one roof, and we're able to do all of it. We get samples from outside with endorphs, and we've, to our surprise, apart from bacterial and fungal growths, we've also had some rare cases of atypical cells, which we've gone back and also seen them to be cases of lymphoma. I'm not going to bore you people, but please make sure your lab is equipped with all media of all covering everything, and sending in to the OR is extremely essential that you've covered everything. You can't just send a blood agar and a chocolate agar and then ask for other things. This is part of our setup. It's extremely important to have validated instruments at the right temperature control, good biosafety cabinets, trained technicians. Over the last 100 cases that we've done, our most common ones have been aspergillus and fusarium. You saw a case of fusarium being presented by Dr. Manisha, and then the third commonest is the candida. We get a lot of, we have immunofluorescence also. We've learned a lot from Dr. Dipankar, who's, in fact, we've taken the dye from Dr. Manisha and we started doing that, and to our fascination, it's been a combined, it started with a WhatsApp group, and then we reached out to Dr. Manisha, who immediately gave us that, and we see some fascinating funguses. Maybe Dr. Manisha would not find the pictures great, but we find them really nice, and they can be used for publications also. Amongst the bacterial, the most common is staph, followed by strepto, and then Pseudomonas. So I'm not going to tell you, but I definitely would like to tell you, let's have conversations between clinicians and pathologists and microbiologists. Let's communicate, let's be vigilant, let's use the right regroup, reevaluate, and monitor so that the patient's clinical and labs care is excellent. So this is why our talk was a little different from all the rest. I had many cases of pathology, but we wanted to do this and get you interested in something which probably interests everybody in this space. Thank you.
Thank you.
Thank you very much for that very interesting case and conversation. Our
This case,
next
Dr. Manisha,
presentation,
actually, the treatment stage for fungal endophthalmitis is the vitrectomy is the main treatment. Probably you have done vitrectomy earlier and a fungus behind the iris which was not taken out. That is why it has again reoccurred.
Absolutely,
And
sir.
even after that fungus, you have given cryo, that might have caused detached fungus, and again you have to do vitrectomy. So vitrectomy still remains the main treatment for removal of the fungus.
So when I have done the cryo, I have already vitrectomized the eye.
Yeah, already vitrectomy, but with that vitrectomy, whole of the fungus has not gone. Still some fungus was there behind the iris. That is why recurrence
I
has
totally
occurred.
agree.
And then also again you have to do vitrectomy to remove the fungus. Even after cryo, you have to do again vitrectomy. with that.
Absolutely, sir. So we need
actually
to
removal
understand.
is the treatment. Fungus has to be removed, otherwise.
But sir, you cannot be sure that you have removed the entire fungus even when you are doing a vitrectomy. You cannot be sure that you have taken out the microorganism completely from the eye. So when you are doing a vitrectomy, you are thinking that you have got rid of the microorganism, but because these are lying behind the iris and that area is not approached when you are doing a vitrectomy. The maximum you will do is clear up the anterior hyaloid face. So if you have some fungal hyphae which are having a propensity to be sticking behind the iris surface, they will grow again. So ultimately we have to resort to a more extensive procedure like a transscleral cryo and get rid of that.
thank you very much. We need to move on. Yeah. Our next speaker is Dr. Jyotirmoy Biswas, who will speak to us on the cytopathology and uveitis.
So, good evening. I have dreamt of this kind of a forum where the clinician and pathologist can interact in a long time. Today it's possible in the AIS platform, may not be that many people, but we wish to grow and have that good clinician-pathologist interface. Today I'm going to talk on cytopathology in uveitis. Myself is an uveitis specialist as well as ophthalmic pathologist. So I'll show a few cases and highlight the importance. This is an 8-year-old girl I've seen about 25 years back, persistent hypopia and uveitis, not responding to the topical and systemic steroid. What is your diagnosis? We did the anterior chamber tap and it showed basophilic cohesive cells with hyperchromatic nuclei and scanty cytoplasm suggestive of retinoblastoma. This is a diffuse infiltrating type of retinoblastoma which can infiltrate the anterior chamber and doesn't have any mass lesion in the back and can have an ultrasound show no calcification. This is a 7-year-old girl, acute lymphoblastic leukemia. Peripheral blood smear was normal. CSF was negative for malignant cells. He has a white hypopyon with convex border and iris stroma was infiltrated with a whitish lesion. What could be? We did an anterior chamber tap and it showed lymphoblast and plenty of lymphoblasts clumped together, and it was an acute lymphoblastic leukemia and it's a recurrence of the lesions. CSF tap was negative. This is a 20-year-old man, and I can remember in dream also, hypopia and uveitis refracted to the topical and systemic steroid. After 1 week of waiting, we decided that I asked Dr. Badrinath what to do about this case. Hypopyon is not responding. He said, why don't you do a TAP? We don't do a TAP for an acute antidiabetes with hypopyon, and we found that the patient is having a microfilaria. And this patient is a 14-year-old girl, history of fingernail injury, and this patient has granulomatous uveitis, and there is a engulfed lens matter was seen in the anterior chamber aspirate. This is 7 days post-cataract surgery, and you can see a exudative mass lesion in the anterior chamber. Somebody thought that there is a lens matter, but we did an anterior chamber aspirate, and it showed fungal ball, KOH chalcophore stain. So pathologic study is required in infectious etiology, lens-induced uveitis, parasitic infestation, endophthalmitis, masculine syndrome, and required in selected cases only. Pathologic study is also important in many ways, like anterior chamber tap, iris biopsy, vitreous biopsy, retinochoroidal biopsy. Anterior chamber tap is quite easy procedure. OPD procedure, 27 to 30 gauge needle, 1 cc tuberculin syringe, 0.1 to 0.5 ml of the fluid. Culture for infectious etiology should be done because it's the gold standard. So how do you approach? You take a intraocular fluid, do the direct smear or cytospin. A portion goes to the culture and a portion for PCR for molecular biology study. Cytospin preparation machine is 1000 RPM for 5 minutes, and you get a concentrated smears, and this is a case of adenocarcinoma. The patient had hypopyon in the anterior chamber and later on found to have lung carcinoma. This culture is the gold standard, but it takes often long time and often it is negative. Often need to be combined with PCR nowadays with can culture. So real-time PCR, we depend on that one. Is a fluorescent molecule is used to monitor the PCR reaction. Fluorescent emitted by the fluorescent molecule manifolds as the PCR product accumulates with each cycle of amplification. And this is a real-time PCR machine, and this is a 48-year-old male, came to us with gradual progressive dimness of vision in both eyes since 15 days, history of fever 3 months back, fungal endophthalmitis showing multiple areas of retinal exudates with hemorrhage. What we did, we did a PCR for all the viruses and in the infectious organism like toxoplasma, etc. 9 copies of the chikungunya virus was found. As you know, there is no treatment for chikungunya, and we did the treatment with the steroids, and there is a complete resolution of inflammation. And this is just, I just have 2 minutes time. Multifocal serpiginous choroiditis, we did the PCR study, and aqueous aspirate was positive for Mycobacterium tuberculosis DNA. Real-time PCR showed multiple copies of the Mycobacterium tuberculosis DNA. Real-time and nested polymerase chain reaction in the diagnosis of multifocal serpiginous choroiditis. Iris biopsy is required in selected cases. This was a 10-year-old girl, no history of trauma, and had a mass lesion in the iris. We thought that this is a tumor, but when we aspirated that one, that showed aspirated material was KOH chalcophore showing fungus. Iris biopsy is needed, is metastatic lesion of the iris and ciliary body, muscular syndrome, ruptured irises presenting as anterior uveitis, iris and ciliary body nodule, granulomatous uveitis. Vitreous biopsy is required in selected cases, suspected infectious etiology, not responding to the maximum anti-inflammatory treatment, picoanapolytic uveitis, and most important, primary vitreoretinal lymphoma. This is a vitreous biopsy technique, and we take 3 probes and then take vitreous material, and multiple levels of the vitreous aspirate is taken. And you see a malignant lymphoma cells with necrotic background, which is quite important, and you should be very careful about examining the cytopathology and looking for the abnormal cells. And this may be accompanied by the normal inflammatory cells and lymphocytes. This is an 11-year-old boy. This is a switch gear, and I showed one case, 11-year-old boy with gradual decreased vision, floaters. And this patient had got lesions over that one with, say, subinternal limiting membrane lesion. What is your diagnosis? And this patient, a normal ESR, only thing is the serum ACE was elevated. SS-associated through macula showed the subinternal limiting membrane deposits. Is the raised ACE is enough for diagnosis of sarcoidosis? You know, sarcoid children is the ACE level is all often high. We asked the opinion from the experts, and they said that can go ahead for the vitreous biopsy. And vitreous biopsy showed in this case cohesive blue cells, malignant retinoblastoma cells. So it was an atypical presentation of bilateral retinoblastoma with protest and subinternal limiting membrane. Cytopathology and polymerase chain reaction of the vitreous fluid in tubercular intermediate uveitis. This is a case where I got a dense exudates in the vitreous. We took a vitreous biopsy which showed granuloma. Macrophages were seen, and the PCR suggestive of Mycobacterium tuberculosis DNA amplification was seen, and it was suggestive of tuberculosis. This is a 50-year-old male, and then had woolly strand of vitreous opacity. We did a vitrectomy, and the optical vitrectomy showed concomitant positive vitreous amyloidosis. Fine needle aspiration biopsy, this is a 14-year-old girl, sudden dimness of vision for 1 week, and we did a fine needle aspiration biopsy. Few AFB was seen, but PCR showed MPV for FNAV was positive. And what happened to the patient? Dramatic improvement with ATT treatment, complete resolution of inflammation. In conclusion, cytopathology is required in selected cases, should be done after morphologic diagnosis and other investigation, must in a muscular syndrome, should be combined with PCR and culture in infectious disease, and should be correlated with clinical findings. I'd like to dedicate this talk in the memory of Dr. S.S. Prabdhbhushan, Dr. S.S. Badrinath, who has brought the modern ophthalmology, academic ophthalmology in this country, and I'd like to follow the life and legacy of this great man. Thank you very much.
Thank you very much, Dr. Biswas, for that excellent talk. Thank you.
0.5.
Right now, I'd like to invite Dr. Deepak Edward to give the oration, keynote address.
Do you have to replace the saline sometime?
Well, good evening, good afternoon. Thank you very much for inviting me for giving this talk. So my talk is 15 minutes, I think, not 5 minutes. So I just, so what I want to do today is give you some updates and also point out that routine pathology may provide a new understanding of disease. Then we'll talk about how ocular pathology combined with molecular omics has revolutionized diagnosis, pathways, prognosis, and treatment, how pathologists are playing a role in that, and ophthalmic pathologists. Briefly talk about artificial intelligence and ocular pathology, and then end with a shout out for all ocular pathologists and oncologists to collaborate and come up with new information in the field of oncology and ocular pathology. So here is a interesting series that I collaborated with folks from LVPAI, and this is a patient or a group of patients with congenital aphakia. And the question the clinicians asked was that if you do a PKP in these patients, all these eyes go into phthisis. And the question was why. And so everybody had stopped doing PKPs for these children with these opacified corneas. And you see how the eye has undergone phthisis. So we were able to give an answer looking at the pathology. So here's a cross-section to the cornea. And what has happened here is because of a developmental defect, the ciliary body and ciliary epithelium is stuck to the posterior corneal surface. So when you do the penetrating graft, you're taking out the secretion of aqueous, and that leads to phthisis. So that was we were able to answer is because of this anterior segment dysgenesis, you ended up with this clinical problem. So also you can generate new information by routine histopathology when you have a large collection of biopsies available. So, both clinicians and, ocular pathologists are familiar with plexiform and, diffuse and neurofibromatosis. These are the usual types. And we usually look at them as separate entities. But when you have a large collection of these samples, we found in a study a few years ago that not only are they separate tumors, but if you have excisional biopsies or debulking of a plexiform neurofibroma, those can transform into a diffuse form and recurrent forms, and we use histology and IHC to show this. And here you see a case which presented as a plexiform, ended up becoming a diffuse form with only small islands of plexiform tumor left behind. Now moving on to omics and eye pathology. So, studies at the DNA level, the RNA level, and protein level have revolutionized how we function as eye pathologists and interact with the clinicians, where this material is extracted, run through different molecular approaches, and in the end you have marker identification and then including drug target discovery. So here you have a very complicated diagram, and this approach has been used in the eye and diabetic retinopathy, AMD, to discover new medications, and also glaucoma, corneal dystrophies, keratoconus, and myopia. So all these have been studied, these different types of omics, and new therapies have been developed. We, a few years ago again, looked at neurofibromas when I was in the Middle East, and in collaboration with my colleagues at Johns Hopkins at that time, we found that these neurofibromas, if you looked at them using RNA sequencing, you could identify very distinct transcriptional pathways, and we found that these pathways were amenable to some of the new small molecule and antibody type treatments, and they're doing a trial now at Hopkins to validate these results. Now, as all of the pathologists and oncologists probably know this, that we've learned a lot about uveal melanoma through omics, and as we were talking earlier as a group, that pathologists are becoming extinct. Our role has become minimized in these tumors. And we've known that there are new driver mutations for choroidal nevi, and then gene expression profiling, as shown in this slide, has pretty much dramatically changed the way we look at tumors, where you have class 1 tumors, class 2 and class 2 tumors, and the metastatic potential for a class 1 is almost nil. So all you need is a final aspiration biopsy to do this, and you're able to prognosticate this into class 1 and class 2 tumors. And if you add on antibody staining with PRAME, you can also improve the predictability of prognostic accuracies, much superior than TNM staining. Why do we need to understand this? Because we do have new pathways available, molecular treatments for treatment of metastatic melanoma. And that's where I come into this slide, this publication from 2021, and then this is from the US, basically showing you that this, the tumor is not does not express PD-L1, so does not respond to checkpoint inhibitors, but you still have immune mechanisms in the tumor. So you have this T-cell receptor immune mobilizing antibody that can be used, which binds to the T cells. And basically, this drug got FDA approval in 2022 for the treatment of non-unresectable metastatic uveal melanoma. This is one of many drugs that are in trials, and this particular drug has shown an improvement in survival by 6 to 8 months compared to, may think it's not a lot, but this is a first start in the treatment of metastatic melanoma, which was before considered almost non-treatable other than very heroic surgery to resect the liver. Liquid biopsies have also become a very important armamentarium, and this paper by Dr. Jesse Berry, basically in the eye. The concept here is shown nicely on the slide, where you have low tissue tumor availability, and then cell-free DNA which circulates in the blood. So if you have patients, for example, they have in early stages, the tumor is aggressive, you can find these cell-free DNA, and especially useful in recurrent tumors, and even we know that this is useful in retinoblastoma, as I'll show you in the next slide. So this is the paper that I was talking about. So you can actually find cell-free DNA in the anterior chamber aqueous, and not only it's sticking a needle in the eye with retinoblastoma is not the best thing to do because of the risk of metastasis. So you can actually, from the aqueous, not only identify the RB1 mutations, but also look at copy number variations which help in identifying prognosis, and also MYC and amplification. And based on just an aqueous humor tap and doing gene sequencing on cell-free DNA, you can really personalize the treatment of retinoblastoma patients. A similar approach has been recently published for uveal melanomas, where you have circulating tumor DNA. You can identify, and these patients who have that are at a high risk of developing metastatic disease. Now, we've also used this omics type approach with a group of collaborators from around the world. Jim Rosenbaum was the main person looking at this, looking at orbital inflammation. And the point that came out of the study was that, it's really, you have common gene signaling pathways in a group of heterogeneous diseases. And the point is that you have drugs available on the market now which can treat these diseases. So this is a drug approved for thyroid eye disease, but this can be used probably for other diseases other than thyroid eye disease. A brief word about AI, and there's not much in eye pathology. We usually the number of samples are less, but I came across this very interesting study this year. The point is, it's a very busy slide, but basically what these authors did was they looked at low-resolution photographs and processed them by AI, and found that the AI was able to be equivalent to a super-resolution path scanner slide. So you got as good data out of the low resolution by using AI. You can do that. Also, the GPT model is being now, there are models in dermatopathology where it can generate a lot of text and analyze the clinical inputs and also the research papers and pathology reports, and give you more informed decision for planning. So there are papers in dermatopathology describing the use of these large language models. So my last slide is basically a pitch for all the ophthalmic pathologists, and we're very fortunate to have a very active group on WhatsApp to share cases. And here you see a large multinational study that was able to validate the WHO classification. I think I make a big pitch here for all Indian ocular pathologists and pathologists to get together. You have huge amounts of data, and this is, I think, going to be a very useful contribution to the field of ophthalmology and ocular oncology. So thank you very much for your attention and for inviting me for this talk. Thank you. So we're waiting for, I think we're done with the session. If there are any questions for any of the people in the audience, please free to ask. We have a few minutes.
Generally, they say lens placode develops at 28 weeks of intrauterine life. And if the lens placode doesn't develop, that fetus never survives. So that is it. We have never seen practically a case of congenital trachea.
There are three types of congenital aphakia. There's a primary congenital aphakia, which these
want to ask Dr. Shruti and Dr. Harsha, the case that you have shown, juvenile lymphoma or a young person lymphoma. Now, was there in the lymphocyte any eosinophil? Because again, the allergic component was thought. Secondly, now, for example, the infectious mononucleosis, EV virus or chlamydia, can it be a possibility?
Well, thank you very much for all attending. So all the speakers, if you can come up or take a picture here.